And it's such a privilege to be able to join you today and to share on this special occasion. I mean, the launch of the report is such a powerful report that's been produced. But that was followed by such powerful stories of what is being done in Ireland. And I think that is something that Ireland has to rejoice in the fact that you have got such a wealth of knowledge and experience and good work going on, and yet you still have difficulties. And that reflects really on how much there is still to do. When you've got such an abundance of good work and a policy, and you still have issues, then you as a country have to look on the other countries that have nothing. And I mean nothing. They don't even know men's health exists, and how important it is that you stand out as a beacon. And what you were doing this morning was showing that you can do that, and do that extremely well. Now this talk this afternoon is about emerging issues in middle-aged men. And I sort of thought, well, where do you start? So I thought, well, let's have a look at a few middle-aged men. And I used Irish middle-aged men in the Google images. And I was expecting to see Noel Richardson as a key prominent Irish middle-aged man, but he's not there yet. So it was a great shame not to see his face. But the thing was, if you look at the top, there's all these different categories that you can go into: attractive, hot, handsome, middle-aged, white, and how those reflect. If you go through, it keeps going and keeps going and keeps going. But these men come in many, many different shapes and sizes, and they come in many different complex issues. And what I want to try and do today is, one of the most important emerging issues is to reflect on what that complexity means, and how we as a group of people talking about men's health have to grasp hold of the fact that we're not one group. We're not just men. We are men of many different backgrounds, many different social situations, many different complex issues. If you look at the data, it's actually interesting, because this is ischemic heart deaths, not rates, deaths. And you can see that actually for ischemic heart disease, we're seeing lots of decreases. And I've got a range of countries: Kazakhstan, where we were recently, Spain, Ireland, the UK, and lung cancer as well. You're seeing that we're having some successes with lung cancer and with many of the cancers that we're getting better at identifying. And as Brona was saying that before, now we're getting to the stage where actually we're living with these conditions rather than dying from them. And that, for middle-aged men and going into older years, is actually of great relevance. We have to think about how we support men as they have diseases and disease processes that thankfully no longer are death sentences. Suicide, though, we're seeing some changes, and suicide is going up. And we can see it. These are numbers, they're not rates. So obviously big countries with large populations will see higher numbers. But in terms of trends, you see some countries that are really seeing significant rises in their middle-aged male suicide rates, but also some countries where you're seeing some decreases. But this is men generally. And when Noel and I wrote this paper in 2011, we were saying that you need to identify men within your research, within your policies, within your strategies, and we have to be recognizing the key issues that men experience. Men as a group. And we've done well, I think. I think when you consider that we've now had the the State of Men's Health in Europe report, we've now got the excellent opportunity through the World Health Organization to be looking at men's health for a report and a strategy, we've got a lot to be proud of. Last couple of years ago, 2 years, 2016, we were commissioned by the Leeds Council, the Leeds Public Health team, to say, well, so what is going on in Leeds? And we did a big study, 400,000 males, first time any city had done an analysis of its entire male population. And what has been remarkable is how much has changed since we did that report, and how it's influenced now nearly all the commissioning of all the services that have been being financed by the public health team within the city. But it highlighted a lot of the stuff we knew, but it also started to shine a light on things we hadn't realised. And one of the main recommendations from this is that we have to be better at working around the social determinants of health, at trying to identify what are the factors that actually are making this an issue. What are the factors that are influencing and affecting the lives of these men? And we have to reach out and target men more effectively, but also at the societal level. Some of the things that we found which were of surprise to the council because they hadn't realised. Almost 1 in 5 men live alone, and this morning we were saying about what's the role of women. Well, actually a lot of men haven't got women around them to have any kind of supportive role. And we also found that the housing situation for a lot of the men that needed social housing, they weren't seen as vulnerable by anybody. They were invisible within the system. There was no strategy for dealing with vulnerable men. And so they tended to end up in the only accommodation that was available, which was the high-rise flats. And in some of these high-rise flats, 70% of the population were male between the age of 30 and 61, with a high level of low self-esteem, low self-worth, low educational attainment, few jobs, high levels of depression. And that contributed to the 5 times higher rate of suicide in the men in the city as compared to the women. And we also found that, in support of a lot of you know, around the fact that men are more likely to become homeless, but the route to homelessness was a factor that people still had difficulty grasping hold of. So why are they homeless? We also looked at employment. And interestingly, it came out that 70% more men than women in Leeds were registered as unemployed. 60% more men than women who were workless for more than 2 years. And of those in work, 3 times as many men compared to women, at least 49 hours a week. So we had two sides. We had a big group of men who were unemployed, but those who were employed were heavily engaged in their jobs, putting in many hours, which has another additional level of stress on them. We also looked at education, and a significant proportion of the boys coming through the system were failing from the very first go. We found that there's parts of the city where some of the men had, 40% of the men had no qualifications whatsoever going into their adulthood, and how that impacted on their ability to live a life, a productive life, and what impact that had on them. And we've got a paper out on this, if you're interested, Social Determinants of Male Health in the BMC Public Health. When Steve Robertson did a study with the Mental Health Forum in the UK on the health of men in the London Borough, they found that over 72% of men presented with a combination of lifestyle risk factors. And when they analysed that, they found that there was the predominance of co-occurrence with unemployment, widowhood, divorce, separated, and interestingly, white British men. And even in Leeds, what we found was the group that came out the worst of the worst was white British men. And a lot of the communities within Leeds, the African community, the Asian community, had a sense of community, whereas a lot of the white lads didn't have a sense of community, didn't feel as though they fitted. There was nowhere for them to go to feel as if they were part of a group that was for them. And it's an interesting insight into how some of the groups that we've not seen as problematic actually probably are going to become more and more problematic. When the World Health Organization put together its strategy for pulling together the men's health report and the strategy, when I say the strategy, I'm meaning when we started planning this, we're looking at the trends, we're identifying the barriers, we're looking at the governance issues, but we also want to address the links between the risk factors, masculinities, their social, economic, cultural and environmental determinants. So we had to start to think broader than just looking at the data. We had to start thinking about what are the causes of the issues and how could we perhaps work with them more effectively. one of the things they did was they said we had to look at the life course. Now, to me, life course has traditionally sort of been thought of, well, they're young men or they're older men. Now, that's not life course. Life course is trying to explore what has happened within your life that has impacted on where you are today. And here we are today talking about middle-aged men. And I think it's really salient point at this time to think, well, who are we? What has been our heritage? What have we experienced through our life that has made us where we are today, that has given us the challenges that we're experiencing today? And they presented the mental health life course where you've got the prenatal, the childhood, the adolescence, the young adulthood, and the adulthood. And I think it's very key for us to think here, what has gone before us to give us our way of dealing with mental and emotional difficulties? And how may that differ from a 20-year-old? How may our experiences of mental health differ from a 70-year-old or a 30-year-old? And how then can we interject? How can we come into this and give a different level of support for middle-aged men, rather than thinking we can just target men? Because the way we target men generally may have no relevance. And it was interesting looking at Hammock's paper. Hammock was at a conference of gay men, and he was in his 30s, 40s, and there was the older gay men were talking about the challenges of their lives, and the young men were saying, look, we don't want to use condoms, we don't want to live our lives like you lived your life, we don't want to be burdened with what you were burdened with. And the older men were saying, look, that's ridiculous, that's not the way you should be thinking. A generational split. Their analysis identified that those in the 70s, 80s were hit hardest by the sickness era, where they had friends, relatives coming through. They'd lived through the Stonewall. They'd lived through the opportunities that were going to be given to them as gay men, and suddenly they were decimated by the AIDS epidemic. The Liberation group coming through in their 60s, 70s missed that first bit a bit, but when we get into the 50s and 60s and the 30s and 40s, these are groups that have come through at different phases, so they haven't lost friends, they haven't lived through something which has been so dramatic. And to the younger ones, who it's all history. The World Health Organization also talks of the social determinants of health, and we know these, we've lived with these. Everyone in this room will have had a very strong connection to the social determinants of health. Employment, social exclusion, women and gender equality, child development, health systems. They may look at it from a different perspective, from a policy perspective, but they're still very familiar. But if you look for men in their these middle years, what kind of issues are emerging? What were we told about our life, of what we were going to do as a man when we were growing up in the 60s? You know that Kipling, show me a boy of 7 and I'll show you the man. Well, at 7, I'm 58 now. At 7, it was 68. At 68, we would be expecting to have a job. We would be expecting to live our life as our fathers had done, as our grandfathers had done, as our uncles were doing. And so for many men coming through now, this massive change in the way that work is evolving, very vulnerable workforces, involuntary part-time work, involuntary zero-hour contracts, working in more feminized areas. And that came very strongly from this morning about how these men's lives were having to reconceive themselves, rebuild an image of themselves as to what they felt they would be working to, how they would be working, and how their role within a family would pan out. I've been following suicide from 2007, and what you can see from 2007, I don't have a pointer, but middle years, suicide is getting higher. But also, in the older years, as the recession has hit home, how much that has impacted on the working age and the older age population. And a lot of this has been put down to recession. And the Leeds study that looked at the audit, over the period, 2 audit periods, 2008-9 and 11-13, women's suicide hasn't changed, but men has gone up. But is it just about socioeconomic factors? In Glasgow, the Glasgow effect, some of you all have heard about the Glasgow effect. They have very low levels of life expectancy. And it's getting bigger. In 81, the gap between what they experience is 4.1 and 9.8 now. And in the men under 65, it's risen to 20. That's the difference in life expectancy between the average population across the city, or across the country, based on the Carstare index and what they're experiencing. And you think, well, what has caused that? When Manchester and Liverpool have almost the same socioeconomic status. So is it poverty that causes men's difficulties? Well, they're saying not necessarily. And I think this is where we have to start being more creative in thinking about the issues. We tend to hone in on some key mantras. Men's problems are about poverty. It's not about poverty. It's often about our history. It's often about the history of how we have been treated, how we have been supported, how we have been enabled. And a lot of what came out of the Glasgow study was this vulnerability to social factors that was beyond the deprivation, and the history of how they had been treated. They felt they had been treated by society. So, different experience of deprivation, weakened social relationships, relatively greater stress, increased amount of drinking, poor coping mechanisms, very negative health outputs. Intersectionality of men's health is all about gender and ethnicity and race, but it's more than just the summation, it's the parts. We talk of gender, and we talk of race, and we talk of ethnicity. Do we actually ever try and think about what it means to be a disabled black young man who is homosexual? And how is his life affected through those combination of those factors, rather than just being blinkered into thinking, oh yes, we take ethnicity into consideration. And what is gender? Masculine, male, female. We've now got a plethora of different ways of living our lives. Masculine, feminine, hegemonic masculinity and emphasized femininity. Where are we in this mix when we glibly talk of gender? This is Tyler Ford. I don't know if you've ever met Tyler Ford. Tyler Ford classes himself, herself, themself as agendered. Is not transsexual, not living a life of agender. And for some of us that have been brought up in that polarity of male-female, and think it odd when there's another box to tick off. But for that person who wants to tick that other box, how important is that? And how marginalizing and negative it is for them to be living in a world that doesn't give them another box to tick. We talk of disability, but we think of disability as physical disability. The world of the deaf. I had the privilege of working with the deaf community in Leeds, profoundly deaf from birth. And the health consequences of being profoundly deaf. This feeling of being in a cultural minority where your mental health is so badly affected by your experiences. And not just your mental health, but lots of physical aspects of your life are also affected by that disability. But are we conscious of that when we're talking about men? Rural masculinity. I fitted this one in when we were talking this morning about rural lives. Going back to Steve's great work on rural masculinity, rural men's mental health within my excellent book on promoting men's mental health. I'm sure he'd do the same for me. I'm sure he'd do the same. Strength, rationality, self-control, sufficiency, stoicism. Being a rural farmer is actually a really empowering and masculinizing way of living your life. Hypermasculinity, physical labor, rational mind. What happens when it goes wrong? To fail as a farmer is seen as to fail the expectation of other family and community members. Ultimately, it means to fail as a man and to lose one's identity. Consequently, farming masculinities entail a constant struggle to perform in order to survive. So when we talk of men who have lost their livelihood, lost their health, lost their will to live within the rule, it makes sense when you start to think about their lives, their histories. What were their fathers like? What were their grandfathers like? There's 65.6 million people who are displaced in this world, and they are finding themselves moved around. Have we thought about, when we talk about ethnicity, migrant men, refugee men, what's the difference between someone who's chosen to come and live in Ireland as opposed to being driven to Ireland by war and persecution, and how does that impact on them as an individual? But it turns out it's emasculating. Work is scarce, dangerous, low level. Men are housed in substandard accommodation with many to a room and poor sanitation. This is the same for women. But actually, if you look at the statistics, a significant proportion of early people coming through are still men. Or we hone in on the women because we know that they are going to be vulnerable, but miss the men. We tend not to think of the men as being a vulnerable group. We don't think of male trafficking. We don't think of male rape. We don't think of the fact that many men who have been through war situations may have been raped. And male rape is now a weapon of war, recognized weapon of war, and it was used widely across Europe. This isn't something which happens over there. This has happened within our own countries. Or survival sex work. When we talk of the gay community, we don't think of those men who have sex with men because they don't fit in any of the many categories. We don't think of those guys who are engaged in surviving, and the only way they can survive is to engage in sex work. And actually, when you look at the data also, of all those refugees that come in, nearly all the ones that are sent back are male. And if you're gay being sent back to a state where there's state-sponsored homophobia, then how is your life going to pan out from there? And what fear are you living in this country, waiting for that decision to be made? So intersectionality is a complex issue. It isn't just a straightforward, oh, we'll look at this, we'll look at that. It's not about looking at the categories of difference and saying, oh, black men, that'll do. We've ticked off black men. We've got to think about how those black men's lives are affected by all the different factors that impact on them, including the socio-economic, including their sexuality, including their disability, including the social factors. But when we do that, we start to reveal more nuanced ways of working with them. We start to realise that actually all the things that Noel and Shane have been working on in their report about working with minorities stand out as being of worth. Because unless we start to think that way, we will never change our ways. And it's not just the category, it's our identity, it's our position. I may be a white, middle-aged man on the cusp of older age. Thank you for those classification groups, by the way. On the cusp, but am I okay? Do you know my history? Do you know what I've experienced over the last few years? I can be seen to be a successful man. I could actually be a very depressed man who is performing today because this is what I've been asked to do. Just to let you in, I had 3 options for this talk. I had 2 easy options and a hard one. And I said to Noel, never ask Noel. I said to Noel, which one should I do? A hard one. So to finish, I haven't talked about masculinities, but if you do work in masculinities, this is an excellent book that's just come out. I don't very rarely give plugs, but it's Messerschmitt talks of dominating positive masculinities. Bridges and Pascoe talk about the myth of the hybrid masculinities, of the new ways men are presenting themselves, but how actually that can mask the stickiness of male dominance. and how it's difficult to get change ultimately within a society. And Connell, again, does an excellent presentation of how masculinity has to be seen as an evolving, performative action that is occurring all the time. So to finish, our world is becoming more challenging, not less. Changes are happening that impact on our identities and our sense of self. And the middle-aged years, I think this was said this morning so profoundly, was these middle-aged years, we're coming to the end of our working life. And actually, our history, like with the gay men, if you look back and think about what it was that we were told we would be doing at this point in our life and how much has changed. I've got 2 boys, they're late 20s, early 30s, they're living their lives very different to us because their expectations were very different. They hadn't been brought up in the way that we had been brought up. And we have to think specifically about the challenges we are facing in our age, both male and female. I'm busy working on the female health, state of women's health in Leeds report as a consequence of the men's health, because everyone's health is important and the gender relations that we exist within has to be seen as important, and the transformations that we all have to go through are important. And actually, as Kimmel, I think, said, we have to go through the pain of that transition. But unfortunately, a lot of people, in going through the pain of transition, may actually find they fall off the perch. So we have to broaden our views of diversity, and we have to think about men's health in a different way. But I think the future is positive, because when you listen to what was going on this morning, and you listen to the ways in which we realised that actually men were crying out for this. They weren't reticent in the background. They were needing this. But we have to break through that to be able to give them permission to join in. And as they join in, their physical health, their mental health, and their social health improves. And on that positive note, hopefully I'll finish. Thank you.